We are very pleased tonight to have Dr. Andrea Yancey, who is an assistant professor of surgery at the University of Louisville School of Medicine and University Surgical Associates, with us tonight. I'm Christine Vokey from PXE International, Director of Education and Information. Dr. Yancey is going to tell us about the vascular manifestations of PXE, how to know the signs and what to do about them. Dr. Yancey got her doctorate of medicine from the University of Tennessee College of Medicine in Memphis. She completed her general surgery residency at the University of Tennessee College of Medicine in Chattanooga, and she followed that with a vascular and endovascular surgery fellowship at the University of Kentucky. She's currently board certified in general and vascular surgery, and she practices as a vascular surgeon at the VA Medical Center at the Robley Rex VA Medical Center and Norton and Jewish Hospitals. Welcome, Dr. Yancey. Thank you for being here, and we're ready to start.
Okay, thank you. Thanks, everybody, for joining in. So as you know already, we're going to be talking about vascular disease and PXE, and I want to give you some information on how to know the signs and the symptoms of vascular disease and PXE, and some certain things that you need to make sure that your physician can do for you to help take care of yourself and watch for these signs and symptoms. As most of you know, PXE is an inheritable disorder that's autosomal recessive. It is a connective tissue disorder that leads to the progressive mineralization and fragmentation of elastin fibers, and it predominantly affects the skin, eyes, and the vascular system. So obviously we're going to be talking about the vascular system today. The heart is at the center of the vascular system. The arteries carry blood away from the heart, and the veins bring blood back to the heart. So I just want to make sure that we're all on the same page. We're talking about arteries today. When there are blockages in the arteries, oxygenated blood cannot reach certain areas of the body, and so your symptoms of vascular disease are going to depend on where these narrowed blood vessels are and which organs are not getting enough oxygen because of those narrowing. So as you can see, it's a systemic problem. It goes to multiple organ systems, including your heart, your brain, your arms, your legs, your kidneys, your intestines, and so we're going to be talking about all those today. The blood vessels become narrow due to atherosclerosis, which is a basically plaque that builds up in the arteries. It's made up of smooth muscle cells, inflammatory cells, lipids, cholesterol, calcium, and it has a fibrous cap to it. This arterial disease or buildup of atherosclerosis in the arteries affects a significant number of people in the United States. So even if you don't have PXE, this is going to be good information for you to know. And like I said, since blood vessels go to different areas of the body, it is a systemic disease, and it is associated with high rates of cardiovascular morbidity and mortality. It is the leading cause of death in the United States. This is a graph depicting the general prevalence of peripheral arterial disease. If you'll notice, as you get in your 60s and 70s, it becomes more prevalent up to 20 to 25% as you get older. And of course, in PXE patients, this occurs much sooner, usually after the 4th decade. So in vascular disease, as I stated, it occurs prematurely, and it generally affects the medium to small vessels. Any patient that's diagnosed with vascular disease at a very young age, they need to be considered for the diagnosis of PXE. In PXE, there is a slow course of vessel narrowing and calcification, and because it occurs over such a long, slow period of time, your body has time to create blood vessels to grow them around these blockages, and therefore it is an infrequent cause of severe symptoms. Histologically, it looks the same as regular atherosclerosis, and what that means is if you took a PXE patient and a regular patient that had vascular disease and you looked at it under the microscope, it would look the same. There is not a lack of integrity to the blood vessels. There are a lot of vascular disorders that where the blood vessel actually is hard to sew to, it's hard to do surgery to, and the blood vessels fall apart. So that's at least one thing that PXE patients don't have to worry about. And as with anything else with PXE, it has a highly variable presentation. Calcifications in the blood vessel not only occurs in PXE patients, but it also occurs in regular atherosclerosis, patients with diabetes, as well as advanced age. It usually occurs in the elastic layer of small to medium-sized arteries, but particularly in PXE. It can also occur in larger blood vessels as well. It can affect the small arterioles underneath the mucosa of the GI tract and in the stomach, and that's one of the things that can lead to bleeds in the GI tract when these arterioles become calcified, fragile, and they break. So the mechanism of the mineralization of the blood vessels is unclear. It's unclear in diabetes, it's unclear in regular atherosclerosis, and it's certainly unclear in PXE. But it has something to do with a chronic inflammatory systemic state that is created, and where the inner lining of the blood vessel is injured in some way. And we're going to talk about some of the ways that the inner lining of the blood vessel gets injured, which increases the progression of vascular disease. So at first, we're going to first talk about these risk factors for peripheral arterial disease. When I say risk factor modification or lifestyle modifications, this is what I'm referring to, these that we're going to go over extensively. We're going to beat it like a dead horse. At first, I just want to go over some uncontrollable risk factors briefly, and then we're going to go over controllable risk factors. Uncontrollable are going to be like PXE. You can't control the fact that you have it. There was one paper that demonstrated the carriage of just one ABCC6 mutation gene has shown to have an increased cardiovascular risk. I mainly want to focus on our controllable risk factors. These are the risk factors that are going to help prolong your life and make you healthier. Smoking and diabetes together has been shown to increase your vascular risk up to 4 times. High blood pressure, high cholesterol, obesity, sedentary lifestyle, and a stressful lifestyle and tension. Firstly, some lab work that you might want to get checked by your doctor. Your cholesterol and lipids need to be checked yearly, okay? I also want to briefly go over homocysteine. Homocysteine is an amino acid that your body needs and uses, but when it's in an elevated level, it can cause an injury to the inner lining of the blood vessel. It has been demonstrated to be elevated in up to 60% of patients with significant vascular disease, and it can actually be lowered by folate and B vitamins, specifically B6 and B12. So it may be something that you might want to get checked just as a one-time thing. And also C-reactive protein is something that you can check to look for that systemic inflammatory disease that you can have when you have vascular disease. Smoking is the most important preventable risk factor. The nicotine injures the inner lining of the blood vessel, and it can accelerate vascular disease 10 to 50 times faster than if you were not smoking. The nicotine causes blood vessel to constrict. It also increases resistance in the blood vessel, and it can make your platelets sticky, which leads to clotting off of the blood vessel. The disease severity is related to the pack years, so it's the number of years that you've been smoking times the number of packs that you smoke per day. Smoking doubles your risk for mortality as well as your amputation rate. So it is so important to stop smoking, especially if you are a PXE patient, if You've got enough stuff going on as it is. Smoking cessation will improve cardiovascular or any type of vascular symptoms that you have. It can decrease your amputation risk, improve patency rates after intervention, whether it be a stent or a bypass. It also helps reduce your cardiovascular event rate, and by that I mean heart attack, stroke, cardiovascular death. 3 months after you stop smoking, you will notice improved lung function as well as improved peripheral circulation. And after 1 year of quitting smoking, you can decrease your risk of heart disease by 50%. So the keys to success for quitting smoking is repeated counseling and involvement with your, have your physician involved. It has been shown to improve success if you will quit smoking with a group. You can also join a smoking cessation group, or if you have friends that also need to quit. And there are also some drugs that you can talk to your doctor about that can improve your success. Diabetes has a significant vascular risk as far as morbidity and mortality. It's very similar to PXE in the fact that it creates a chronic inflammatory state with all the circulating glucose and free fatty acids that are created due to the diabetes. This leads to chronic inflammation, vasoconstriction, as well as clotting off of the blood vessels. And the vascular complications are what causes, you know, most of the morbidity and the mortality in diabetes patients. So it's so important that if you have diabetes that you keep it under control. It can help reduce the rate of cardiovascular events. It can decrease your microvascular complications like your eyes and your kidneys. It has not been shown to decrease the risk of peripheral vascular disease, meaning narrowing of the blood vessels like to your legs. In diabetes, there is also a calcification of the media layer in the blood vessel, and like I stated, it's probably due to the chronic inflammatory state that is created. And 1 to 3 people over the age of 50 with diabetes will also have peripheral arterial disease as well. Hyperlipidemia and high cholesterol also significantly increase your risk of vascular disease, particularly for cardiovascular disease as well as stroke. Obviously, the lipids and the fat build up in your arteries, and the arteries become more narrowed. So I want to take this opportunity to go over with you the heart healthy diet. And some of this I realize you guys already know. You know, you need to eat fruits and vegetables, have your required daily fiber intake. Fish is very important. Fish has omega-3 fatty acids in it, and it has been shown to decrease inflammation, lower high blood pressure, decrease the progression of vascular disease. If you are deficient in omega-3 fatty acids, you can have mood swings, depression, dry, scaly skin, and if you will eat 2 servings of fish per week, you can decrease your risk of thrombotic stroke up to 50%. You can also take supplements of omega-3 fatty acids by taking, you know, fish oil pills, but they have omega-3 fatty acids in orange juice now, and they have it in eggs, and so there's a lot of other ways that you can improve your intake of this. Obviously, you want to do a low-fat, low-cholesterol diet. You want to stay away from the fried chicken, French fries. You don't want to double down. If you've seen the KFC commercial where there's fried chicken breast and then cheese and bacon and then another fried chicken breast on top, I mean, you might as well just go to the emergency rooms, you know, and sit in the parking lot and eat it so you can go in when you start having your chest pain. You want to eat unrefined whole grains. If you are overweight, the American Heart Association has demonstrated that you can reduce your risk of death from cardiovascular disease by up to 20%. You can also lower your blood pressure and improve your lipid profile by losing weight. Now, I put this in here at this point because I'm talking about the heart healthy diet, but in general, because I want to talk about calcium for a second. Because you have calcification in PXE, that doesn't mean you need to avoid calcium. You want to get your minimum daily requirement of calcium because your body is going to try to maintain a certain level of calcium in your blood, and if you're not getting it from your diet, then it's can potentially rob it from your bones. So you do want to get your just under or your daily recommended requirement of calcium. And of course, there was the study on the PXE knockout mouse that demonstrated a diet with calcium and magnesium supplementation slowed the rate of calcifications of the organs in the mouse. And I think another study has come out that may show something different, but it's just something to think about. And I went ahead and put in here because people had asked me at the conference, you know, what foods contain magnesium and calcium, so I just went ahead and put that in there for you guys. Statins should be the first line of therapy as far as lowering your lipids and your cholesterol level. Another important thing that statins do is it stabilizes plaque, which was just a really unique finding that they determined from statins, and this can decrease your risk of heart attack and stroke. There are side effects. Anytime you take a medication, you need to evaluate the side effects. And for statins, in particular, liver damage, and you can also get leg cramps. So if you develop leg cramps after you start taking your statins, it may not be vascular disease, it may be your statin. So you just kind of have to keep that in mind. Blood pressure is also a significant risk factor because that pressure causes an injury, once again, to the inner lining of the blood vessel wall. It is significant for increasing your risk in cardiac, stroke, as well as peripheral arterial disease. It's known as the silent killer because you don't really have symptoms. And when your heart has to contract against all that pressure, it also causes significant amount of cardiac stress and cardiac disease as well. Some patients, PXE patients, will have an early onset of hypertension due to the calcification of the blood vessels that occur, and this calcification leads to a lack of compliance in the blood pressure, therefore the blood pressure goes up. Aggressive blood pressure control is very important. If you do have high blood pressure, it will improve your risk of heart attack, stroke, and vascular death. There was a study that showed controlling your blood pressure lower than 128/75 significantly decreased these endpoints. And when I say endpoints, I mean heart attack, stroke, and vascular death. And mainly I just want to emphasize aggressive blood pressure control. If you do have high blood pressure, there have been multiple studies that have demonstrated this, and ACE inhibitors have been singled out also as helping to reduce your risk of cardiovascular endpoints as well. While we're talking about blood pressure, I just briefly wanted to put in the Valsalva maneuver. And if you don't know what that is when you lift something that's really heavy and you hold your breath while you're lifting it, or if you're straining on the commode to go to the bathroom, those are Valsalva maneuvers, and they're not good for you, regardless of if you're a PXE patient or not. It causes kind of a chain of events which can lead to significantly increased blood pressure. So I just want to make you aware of this to not give your body that extra strain. And that's one reason why they tell weightlifters, you know, they need to breathe through the whole time that they're lifting the weights. Exercise can lower your blood pressure. It can increase your good cholesterol, help keep your blood sugar under control, reduce feelings of stress, help you control your body weight, and it helps you slow the progression of vascular disease. So the more active you are, the longer and healthier life that you're going to have. I want to talk about aspirin for a second. It's recommended that patients over the age of 50 take a baby aspirin a day to decrease their risk of heart attack and stroke and vascular death by at least 25%. Now, in PXE patients, this gets a little tricky. There's two problems that come into play with the aspirin in PXE patients. One is the aspirin can lead to ulcerations in your stomach, which can lead to the GI bleed. And then if you're on the aspirin, you're not going to clot off the bleeding as well. So there's the bleeding aspect and the ulceration aspect. The ulceration aspect can be improved by taking, a proton pump inhibitor or H2 blocker, but there's still a bleeding risk. Now, in the general population, GI bleeding was increased from 1.4% compared to 2.5% if they were taking aspirin compared to the non-aspirin. But the risk-benefit ratio of patients with PXE is unknown. There was also some concern expressed to me in regards to the eye bleeds, although there's no data proven that aspirin can worsen an eye bleed. It's still kind of concerning because it does affect the platelets. So you need to really discuss this individually with your doctor. And if you have a significant vascular manifestation of PXE, if you're predominantly vascular, you may want to consider accepting the risks of the bleeding and taking the aspirin. But that would be something that I would recommend that you really evaluate closely with your physician. So in my review of the literature, I determined incidence of vascular symptoms in PXE, and the most common is intermittent claudication, which we're going to talk about at length, probably more than you want to. It was noted to be 18 to 32%, hypertension 19 to 22%. Notice that GI hemorrhage was 8 to 19%. Renal vascular disease was kind of all over disease, and that's blockages in the arteries that go to the kidneys, and we're going to talk about that also. But it was all the way from rare to up to 25%. Stroke and heart attack was pretty low, 1 to 7% for stroke and 1 to 2% for heart attack. Now, I know this is a busy slide, but this is data that has not been published yet. In fact, it's still in the process of being analyzed, but it was collected by PXE International, and they painstakingly collected all this information from about 700 PXE patients so we could help answer a lot of the questions that we still have about PXE. Almost 50% of patients had some type of vascular manifestation, whether it be in the heart or in the arteries to the legs, claudication, some type of blockage or a weakened pulse. Only 6% of patients were noted to have coronary artery disease, and 2% of patients were found to have a heart attack, and almost 2% had reported having a heart bypass. 25% of patients were noted to have blockages in the peripheral arteries, but up to 47% of patients complained of cramping in the calf with exercise, which is basically claudication and suggesting that there is some peripheral blockage causing those symptoms. And the average age of onset for that was 34 years for the peripheral arterial disease. Only 4% of patients, though, required leg bypass. Only 4.7% of patients were noted to have had a stroke. 20% were noted to have a GI bleed, but these numbers still need to be analyzed somewhat because only 5% of those had actually been confirmed to have PXE on some type of muscular biopsy. So some of the bleeds may have been caused from hemorrhoids or polyps or some other cause. But the average age of GI bleed was 32. And also notice average age of heart attack was 50, which is about 15 years younger than the general population. So earlier onset of disease basically is what this slide tells me, but the bad stuff is still in pretty low numbers, like the stroke, the heart bypass, the leg bypass, they're still in pretty low numbers. So that's the good news. So at first I want to just talk about blockages to the legs, and this is often referred to as peripheral arterial disease as well, because the heart is called cardiac and the brain is cerebral vascular. So oftentimes they use peripheral vascular to describe the legs. So you can hear me use that term again. But as the arteries become more narrow to the muscle groups in the legs, when you exercise, you will notice that they become affected. At first you may have blockages that don't manifest any symptoms. And then when you have one blockage, usually that will develop into the intermittent claudication symptoms, which we're going to talk about here shortly. And it may progress to multiple blockages, which can cause critical limb ischemia. The definition and explanation we'll go over here shortly. So intermittent claudication is the first sign of vascular disease in the legs, and it is the most common PXE vascular symptom. It has been reported as early as age 6, but it usually occurs after the 4th decade. What happens is when you exercise, your muscles need more blood flow and more oxygen, and you're unable to supply that blood flow due to the blockages in your legs. So you'll have a buildup of lactic acid in the muscle, and the muscle will cramp up, or you'll have muscle fatigue. This should occur at the same walking distance every time. So if you're on a level surface and you walk 2 blocks, it should occur at 2 blocks every time, so it's reproducible at the same distance. And then when you stop and rest and it has time to flush out of the muscle bed, then it should go away after about 5 minutes. The symptoms usually occur 1 level below the blockage, so we'll talk about that in the next slide. And up to 1/3 of patients fail to communicate their symptoms to their physician. And some patients will have atypical claudication symptoms. They won't actually follow this exact pattern. So here's an example of the most common blockage that we have that occurs right here, just above your knee. So when this patient walks, they need more blood flow to their calf muscle. They're unable to supply that blood flow, so the calf muscles will cramp up, and then when they stop, it'll go away. Same thing like if you have a blockage in the iliac blood vessel, which is, if I can get my pointer, here in the pelvis. You may suffer from claudication in the buttock or in the thigh area, or you can have whole leg weakness. So your symptoms will occur 1 level below the area of the blockage. So if and when your disease progresses to multiple blockages, you can develop critical limb ischemia. This is very rare in PXE patients, but it is usually manifested in 2 different ways. One is rest pain, and the other one is a wound on your foot that won't heal due to lack of blood flow. It can be an ulcer, it can be an injury, or can it just be gangrene? So rest pain, this is basically you don't have to exercise to know that your leg doesn't have enough blood flow. You don't have enough blood flow at rest. So you have severe pain in the front of your foot. It usually occurs at night because you're you're lying down on the bed and your toes are the furthest away from your heart. When you're sleeping, your cardiac index is lower. And it wakes you up at night, and it helps to dangle your foot off the bed so that gravity can help get blood flow down to your toes. It's not leg cramps at night. It's not foot cramps. It often needs to be determined between a diabetic neuropathy or a restless leg syndrome. So I want to go over signs of peripheral arterial disease on physical exam. Most commonly, you'll see a diminished or an absent pulse. You can check your pulse on the inside of your ankle, just behind your ankle bone where it sticks out. There should be a pulse there. And you can also check for a pulse on the top of your foot. You may also notice loss of leg hair if you have diminished blood flow to your feet, thickened nails, pale, cool skin, or if it's bad enough, you may actually progress to having a reddish color, which is called rubor. So this patient here has vascular disease in both legs. This leg is more of a one-level disease. Notice that his foot is pale and he has thickened nails. He probably has claudication in this leg. In this leg, he's progressed to critical limb ischemia, and he's got that reddish rubor color. This is an example of an ischemic arterial ulcer. And this is a patient that had a toe amputation, and they needed to have their pulse checked first before they did the toe amputation because they don't have enough blood flow to heal the surgical incision. So I want to go over diagnostic testing that you can do to check for the disease. Your blood pressure should be the same all throughout your body. So if you have blockages in your legs, you can check a blood pressure in the arm and compare it to the legs and make a ratio, and that will tell you how significant your vascular disease is. Many hospitals offer vascular studies as screenings, so they offer free exams. There are also other tests that you can there are also other information that you can get from your studies. They have little tiny blood pressure cuffs that they can put on your toes as well. You can also get blood pressure cuff measurements before and after you exercise, and they can also be used to follow up after you've had an intervention. You can also get an ultrasound of the blood vessel and directly look at the plaque or the degree of narrowing. So ABIs that are in the 0.5 to 0.8 range are generally the claudication range, and if they are 0.4 or less, they're usually in the critical limb ischemia range. This is an example of some more information that you can get from your ABIs. They can get pulse volume recordings. This is the normal leg. This is the abnormal leg. Notice that the waveforms are widened and more dampened on this side, and they're that way all throughout the leg. So the blockage is most likely above all of these blood pressure cuffs. So it helps you find where the blockage is as well. This is an example of an ultrasound of the thigh artery. The upper image is a normal ultrasound. It has triphasic waveforms with normal velocities, and the lower ultrasound is where there's a stenosis. So notice there is dampening and widening of the waveform, and the velocities are very elevated. So it's just like if you had a water hose that was pinched, the water would go through the hose much faster. So high velocities are indicative of the stenosis. And if you're being considered for surgery or you need additional information, you may get an MRA, a CTA, or an arteriogram. All of these require injection of some type of contrast material to light the blood vessels up so you can see where the blockages are. So now I'm going to go over treatment options to the leg. Main treatment options are going to be medical management. That's going to be our risk factor modifications that we discussed, identifying and managing coexisting morbidities, an exercise regimen, which we're going to talk about, as well as drug therapy. And then there's also surgical options as well. There's surgery that is percutaneous, which means through a needle stick into the skin, like a balloon and stent. And there's also open surgical options as well. You can also combine the percutaneous with the open surgical options and do a hybrid procedure, which I'll try not to get too technical. But so in general, claudication remains stable. 70 to 80% of patients with claudication remain stable over a 10-year period. They are, however, at increased risk for stroke, heart attack, and cardiovascular death. The amputation rate is low, usually 2 to 3% over a 5-year period. So like I said, you mainly want to do your risk factor modifications. I want to talk about the exercise regimen because it's very important, the cornerstone of therapy for symptomatic relief of intermittent claudication. It can help improve function and symptoms, prolong patency of interventions, whether it be stents or bypasses, and it can help prolong your survival. Unfortunately, it has to be performed indefinitely or the benefit may be lost. So we're stuck with the exercise. Exercise regimen includes walking 3 to 4 times a week. What you want to do is you want to walk until your legs cramp, and then you want to try to walk a little bit further so that you're able to increase the distances that you're able to walk over time. It may take up to 12 weeks before you will see a difference even. When the pain that you feel when you exercise is not causing harm to you, but it's actually telling your body to grow blood vessels around these blockages, and it can prevent you from needing a bypass in the future. There are 2 drugs that are approved for the treatment of intermittent claudication, pentoxifillin and silostazol. Pentoxifillin was one of the first ones that came out. It helps decrease the viscosity of blood. It was shown in a couple of papers to improve walking distance, but then a couple other papers it wasn't any different from placebo. And then silostazol came out, and it showed significant improved walking distance compared to pentoxifillin. There is a dose-dependent increase in mortality if you have congestive heart failure with silostazol. I don't use these drugs routinely because I have not seen a significant improvement in symptoms from when my patients take them. So I might prescribe them if I don't have any other options for the patient. But the drugs do have side effects, and I haven't seen an overwhelming significant improvement in their symptoms on the patients I have put on these drugs. Medical therapy for intermittent claudications includes the statins, so we're back to those again. They were shown to improve pain-free walking distance in claudication. The heart protection study demonstrated, they demonstrated a benefit in routine statin use in patients with peripheral arterial disease, regardless of whether or not they had elevated cholesterol levels or not. An ACE inhibitor, which is one of the blood pressure medications, was also shown to improve peripheral perfusion and improve walking distance. And then there have been some other drugs as well which are not approved in the U.S. Some of them are still in IV form, and they're used over in Europe. But one of them that I thought was interesting was the ginkgo biloba has been shown modest improvements in walking distance with intermittent claudication patients. So when do you intervene in peripheral arterial disease? Well, you don't. You do your risk factor modifications, okay? You want to be very conservative. But if you are a mailman and you can't deliver the mail because you're unable to walk, you're going to lose your job or something, when it becomes lifestyle limiting, then you want to consider an intervention, or if you've progressed to critical limb ischemia, meaning rest pain, or a wound on your foot that won't heal due to lack of blood flow. So a couple of intervention options for peripheral arterial disease. One is, like I stated, percutaneous, which is a needle stick through the skin. That usually involves some type of balloon or stent, and then open surgical options, which usually include cleaning the plaque out of the blood vessel, just peeling the plaque out, or some type of bypass. In general, if you have short lesions, they can be treated well with balloons and stents, but if you have long calcified lesions, they do better usually with bypass. The surgery has morbidity and mortality associated with it, but the interventions usually last longer than the percutaneous. There's a kind of a trade-off. But in general, we try to start out with percutaneous interventions first, and then progress to the bypass when needed. So percutaneous options include just plain old balloon angioplasty. There's cutting balloons, freezing balloons, and then you can balloon and stent, bare metal stents, covered stents, drug-eluted stents, and then there's the rotor-rooter atherectomy, which I would not emphatically recommend. Somebody's probably going to get on to me about saying that. But so this is an example of a patient that had an occluded iliac blood vessel with the blood vessel in the pelvis I was telling you about. This is where the blood flow stops. And here's where I got across the occlusion and injected the dye to make sure I was back into the lumen of the blood vessel. Here's the balloon and stent that was placed. And you have restoration of flow. Now, balloons and stents in the iliac blood vessels, because of the size of the location, have a tendency to do really well, and the patency rates are comparable to bypass. This is an example of the thigh blockage that I was telling you that's just the most common. These are the blood vessels that you grow when you do your walking regimen. Here's where I got across the blockage and injected the contrast to make sure I was back into the lumen of the blood vessel. I'm probably getting too technical, but you'll have to deal with it, I guess. Here's the result of the balloon angioplasty and stenting. Short things like that should do well, basically. This is an example of a long blockage. This blockage basically goes from here all the way, all the way down to here. And if you'll see on this next slide, this is where we ballooned and stented it open with a good result, but this did not stay open very long. I think it was 4 or 5 months this stayed open, and then he had to come back and have a bypass done. This is an example of a patient that had balloon angioplasty in his popliteal artery, which is the one behind the knee. And I put this on here because once you see the calcification of the blood vessels that you can see on the regular x-ray. And here's his results. I know I got too excited with the pictures, but anyway, this patient had tissue loss on their foot, and there is a blockage here. So I ballooned it with a 2-millimeter balloon and got a significant improvement in blood flow. So he is not really a bypass candidate, so we were able to save his foot just from doing that one little 2-millimeter balloon angioplasty, which I love. This is also a similar patient that has diabetes, one vessel that comes down to the ankle and just stops. There's hardly any blood flow that's going into the foot. Got one of these small wires across the blockage and ballooned it with 2.5-millimeter balloon, and now you can see the blood vessels in the foot lighting up again. This is just an example of a surgical bypass. This is to the iliac blood vessels, and this bypass lasts a long time, 10 years usually, but it is a big operation. This is a very common bypass operation to blockage in the leg, just depicting kind of what we do there. So now we're going to talk about cerebral vascular, or things that affect the brain, basically. In PXE patients, or in patients in general, stroke can be due to things that are inside the brain as well as things that are outside the brain. Things that are inside the brain are going to be like aneurysms, hemorrhage, and small vessel disease. There are case reports of aneurysms in PXE, but we don't know exact numbers, and it still seems to be fairly rare. And then, of course, small vessel disease, which you know is prevalent in PXE patients. And then outside the brain, there's a blood vessel in the neck called the carotid artery, and this can be a source of stroke in up to 80% of patients that have stroke. So we're mainly going to talk about that. Symptoms of stroke include an inability to move or feel an arm or a leg on the same side, slurred speech, drooping of the mouth, transient blindness in one eye or the other eye, usually lasts about 10 to 20 seconds. And then signs on exam are going to include a carotid bruit. A bruit, basically, if you have a stenosis in a blood vessel, you will have turbulent blood flow. And that turbulent blood flow can be heard with a stethoscope, and it's called a bruit. So you can have that on exam. And of course, if you've had a stroke or stroke symptoms, then you'll have a neurologic deficit. This is a pretty good picture that demonstrates what happens with the carotid artery. The blockage usually occurs right where the blood vessel branches. One branch goes to the face, one branch goes to the brain, and platelets or plaque can collect and travel to one of the small blood vessels in the brain, blocking off its oxygen supply. And then your symptoms will be whatever area is blocked off to that particular area of the brain. Vascular ultrasound is a great test for the blood vessels in the neck. It can demonstrate the plaque as well as the degree of narrowing. And not that you need to know this, but you can also look at the intima to medial thickness, which has been shown to be increased in PXE patients. This is an example of a normal carotid artery. This is the bifurcation. There's one blood vessel that goes to the face, and then there's one blood vessel that goes to the brain. And then this is an example of a carotid artery with a significant irregular plaque. It looks like that this plaque has erupted. If I can get my pointer to work, as you can see, platelets and plaque and debris can collect where this plaque is located, right here, and it can travel to the blood vessels in the brain. Also indicates the importance of statins, and that statins have been shown to stabilize this plaque, and that's how it decreases your risk of heart attack and stroke. This is an example of a cross-section of a blood vessel, showing how much the lumen, or the inside of the blood vessel, and the blood flow is narrowed from the plaque that's present there. So if you're having symptoms of stroke, you want to go to the hospital immediately, because there's about a 3-hour window that you can get the clot buster medication, and you can potentially reverse your symptoms. If you're determined to have a narrowing in the carotid artery, the artery in your neck, you need to talk to a surgeon that's going to give you both the options of open surgery as well as stenting. If you're not given one or the other of these options, it may be because they're not familiar with the other option, and you really need to know about both of these options. In general, the surgery is the standard of care, but the stenting, balloon and stenting, has significantly improved over the year, and it's beginning to approach, but hasn't quite approached, the results of the surgery. And of course, you want to do your risk factor modification. This is an example of the carotid endarterectomy, and endarterectomy basically just means we're cleaning the plaque out, and then we close the plaque, the artery, with a patch so that it's even wider than it was before. And this is the plaque that looks very similar to what we pull out. This plaque looks like it's ruptured here, so this patient might have had some symptoms before they had their surgery. This is an example of what happens with balloon angioplasty and stenting of the carotid. You will access through the groin right here through a needle stick, go up into the neck, inject the dye, and then place the balloon and stent where the blockage is demonstrated. This is an example of a patient that I did a carotid stent on. Here's where we went into the groin, took the catheter up into the arch of the aorta. So here's the heart, okay? Here's the blood vessels going to the brain. and these blood vessels are going to the arm, all right? Here's the neck, see the spine there? Here's the branch that goes to the face, these branches, and this branch goes to the brain. Here's where the significant blockage is, and here's the results after balloon angioplasty and stenting. Now I want to talk about blockages in the arteries to the heart, or cardiovascular disease. When the arteries in the heart are blocked and you have decreased oxygenation to the muscle in the heart, it usually occurs when you are exerting or exercising. You can have a heaviness or pressure in your chest. You can have shortness of breath. You can break out into a sweat or be very weak. Your discomfort may radiate to the jaw or down your arm. And you can also have a silent MI, particularly if you're diabetic and not have any symptoms. This is just an example of a blood vessel blockage to the heart. This is that intima layer, which I've been talking about, that gets injured and thickened in reaction to the injury. And here's the buildup of some plaque and lipids in the artery, causing the blood vessel to become more and more narrow. So testing for heart disease, you may want to get an EKG, chest x-ray, some lab work. Your doctor may want to get a stress test on you. They can stress your heart either with exercise or with drugs to increase the oxygen consumption of your heart. Echocardiogram is also very helpful, which is basically an ultrasound, just like the other vascular lab we've been talking about. And if there's any question about the blood vessels to your heart, you will proceed with heart catheterization, which we'll talk about here shortly. So this is an example of an echocardiogram, which is an ultrasound of the heart. This particular patient is demonstrating endocardial calcifications, which has been reported in PXE patients, and they also have calcification to the mitral valve as well. This irregularity can also be a source of stroke. And I just put this in here because I thought it was kind of interesting. They're looking at coronary calcium scores now. So you get a CT scan of your heart. They look at see how much calcium is there, and then they can determine your incidence of cardiac events based on how much calcium is present. So treatment for coronary artery disease is obviously going to be your risk factor modifications, okay? If you do have a blockage, then you will proceed to have a heart cath where they may do a balloon and or a stent. You may have to have a bypass to your heart. This can also include a valve replacement or not. Or if you have some rhythm problems, you may get a pacemaker. So this is an example of the heart catheterization. You basically go in through a needle stick in the groin here. You can also go in through the arm, and they'll inject the dye and see if there's any blockages in the blood vessels. Now this patient had a blockage in the left circumflex right here. They treated it successfully with the balloon angioplasty. It looks really well. Looks really good. Sometimes they'll put a stent in there as well. And I'm sure you're familiar with open heart bypass surgery. You know, they have to open your chest, and oftentimes we use the vein on the inside of your leg as a bypass to bypass around the blockages in your heart. They can also use the internal mammary artery, which is an artery that runs along the inside of the chest wall. But in my review of the literature, there was some caution noted in using this blood vessel because sometimes it can be calcified in PXE patients. So now we're going to talk about blood flow to the bowel. Basically what we're going to be talking about is mesenteric angina, which is basically claudication to the bowel. So when you eat, your bowel needs more blood flow, And if you have blockages, you're unable to supply that blood flow that causes severe abdominal pain. It can also cause nausea, vomiting, and diarrhea. Eventually, this can lead to food fear. The patients can have a bruit in the abdomen on exam, and they're usually very thin patients. So this is an example of the main blood vessels that go to your bowel, your celiac artery, as well as your superior mesenteric artery. This is the superior mesenteric artery, which fills a majority of the small bowel as well as part of the large bowel. This is a balloon angioplasty treating a high-grade stenosis of the superior mesenteric artery here. Here's your balloon, and then here's after the balloon with a good result there. This is an example of a mesenteric bypass. Basically, you have to do a bypass from the main blood vessel, the aorta, and carry a bifurcated graft down to the superior mesenteric and the celiac artery to your bowel. This is just a CT scan that demonstrates significant calcification seen at the origin of both of these blood vessels. And note there's also some calcifications down here as well. So now we're going to talk about blockages to the kidneys, which is known as renal vascular disease. Your kidney decides how much fluid it's going to hold on to and how much fluid it's going to pee out, depending on how much blood flow it's seeing through the kidney artery. So if there's a blockage in this artery, the kidney will hold on to more fluid, thinking that it's not getting, your body doesn't have enough fluids. It can lead to hypertension. This is called renal vascular hypertension. Usually only causes about 5% of people that have hypertension. Symptoms include not only elevated blood pressure, but a blood pressure that's difficult to control with medications. And this is also where your ACE inhibitor comes in, because your ACE inhibitor will break that cycle, and that's why it's often used as a blood pressure medication. This can be evaluated with ultrasound, just like the same vascular lab ultrasound stuff that we've been talking about in the legs. It can be used in the mesentery, and it can be used in the neck as well as the kidneys. In general, these stenoses are treated very well with balloon angioplasty and stenting and have a tendency to last a long time. Bypasses are usually reserved for cases where you're already going into the abdomen to do some other procedure. Very rarely do you do just a renal bypass alone, but if you do have a failed stent, then you might need a renal bypass, but it's very uncommon. So we're getting there. I just want to talk about GI bleeds for a second. It can occur in approximately 13% of cases, and when it does occur, it can be resistant to non-surgical methods of treatment. If you look at the mucosa of the bowel that's in PXE patients, under a microscope, you can see fragmentation of elastin fibers and in the arterioles, and these arterioles break and cause bleeding. In general, in PXE patients, the GI bleed is usually in the upper part, meaning the stomach or the first part of the intestines, and so the symptoms are usually vomiting blood. You can also, when you do a scope down and look with the camera inside the stomach, you can see raised yellow plaque-like lesions indicative of PXE. And then, of course, you'll have the PXE findings of the elastin fibers on your biopsy. If you have a lower GI bleed, you may have blood in your stool or you may have black tarry stools. So if you're having a GI bleed, obviously you're going to get blood transfusions. You'll get an upper and a lower scope. You'll get some medications to try to get the bleed to stop on its own, but if it doesn't, it may require a complete resection of that portion of the bowel that's bleeding. So my conclusions are several slides, but we are getting there. You want to be able to identify if you have vascular disease. You know the signs and symptoms now. Use your non-invasive vascular labs. You can use it for your legs, your kidneys, your bowel, your heart, and your neck, your carotids for cerebral vascular disease. Many times hospitals will offer free vascular screenings once or twice a year, so you can get online and look and see if those are offered near where you are. You want to get in your yearly exam, not only do you want to get a dilated retinal exam, but you also want to get a thorough vascular exam as well, which we'll talk about in a minute. And something else I just wanted to throw in there is, wear sunscreen and your eye, any type of sunglasses or your regular glasses, make sure you have UV protection. Is there any data on that? No, but, I think it can help. So aggressive management of your atherosclerotic risk factors, which we've talked about extensively. And in general, it's going to be hard to find a physician that's familiar with PXE. So you need to find a physician that's interested in learning about PXE and interested in you and looking for these signs and symptoms. So I've kind of summarized findings on physical exam that you kind of need to keep an eye out on, okay? You want to make sure that you listen for bruits, okay, particularly in the neck with the stethoscope, okay? You want to make sure your physician checks for pulses at the wrist, at the ankle, okay? They need to listen to your heart, make sure you don't have any murmurs or abnormal rhythms. Look for skin changes, not only with PXE, but also for changes consistent with arterial insufficiency or lack of blood flow to the legs, like your lack of hair, your thickened nails, okay? The dilated retinal exam yearly, okay? And then if there's any suspicion of anything, follow it up with your ABIs or your vascular lab exams. They're non-invasive studies. There's no needle sticks. There's no dye. And you can get a lot of information from them. Some food for thought. Remember your ACE inhibitors. They can help you with your blood pressure and also help you if you have intermittent claudication. And antioxidants are always good to help decrease the inflammation, inflammatory response, good for your immune system. We talked about the calcium and the magnesium. Omega-3 fatty acids, I could talk about it for 15 minutes, but they're good, so eat your fish and take your supplements. Ginkgo biloba has been shown to improve claudication symptoms, and it can help your memory, supposedly. And then your lab work, homocysteine level and your C-reactive protein, you might want to get those checked the next time you get your cholesterol checked, because you need to get that checked yearly. And your healthy living, okay? So use your blood vessels or lose them. Be active, exercise on a regular basis. Healthy weight, control your stress, manage your blood pressure, your cholesterol and lipids. Don't double down at the KFC. Decide with your doctor whether or not you're going to take the aspirin, and avoid smoking, okay? So I just want to thank everybody's attention, and I want to thank PXE International for allowing me to speak tonight. Here is my email address. If you have any questions, feel free to email me, and I'm going to turn it over to Christine.
Thank you very much, Dr. Yancey. That was very thorough, and we have a couple questions. We have several questions about calcium and some new information that taking calcium supplements may contribute to deposits in the arteries. And do you have any guidelines on what's enough calcium to take for, heart health and not increase your risk?
Well, calcium requirements are different depending on your age and your gender. But in general, it's 1,000 to 1,300 milligrams per day. So if you take an excess of calcium, though, it doesn't mean that your body is going to deposit it in your arteries and make you have vascular disease. Vascular disease is caused from the inflammatory response on the inside of the blood vessel wall. So, you know, you want to make sure that you get enough calcium in what you eat, and you don't want to avoid calcium to try to thinking that it's going to keep you from getting blockages in your arteries.
And do you think that the calcium you get from food sources is better, and then you would take less of a supplement form?
Absolutely. I think that your body processes calcium better if it's taken in naturally from the foods that you eat. It's very easy to get, you know, calcium from, you know, if you have a bowl of cereal with milk in the morning and some yogurt with lunch and some spinach with dinner, then, you know, you should be pretty good on your calcium for the day. So I think it's much better processed in your foods.
Thank you for that. And you talked a little bit about the fish oil. One person has asked, is there any data that suggests increasing consumption of vegetables and omega-3 fatty acid supplements can reduce or reverse vascular mineralization in people with PXE?
Well, we don't have a lot of data on PXE in general. I gave you pretty much all the data that we have in our talk. So, but I can talk about omega-3 fatty acids and having to do, it doesn't affect mineralization per se. It does decrease the progression of vascular disease. It decreases inflammatory response. The systemic inflammatory response in your blood vessels, and it can decrease your cholesterol level in a dose-dependent way. So the more omega-3 fatty acids you take in, the more it can lower your cholesterol levels.
Thank you.
Did I get everything on there?
I think so.
Okay.
Now there's a man who is asking, exactly how does PXE impact small, medium, and large arteries? And his question has to do with the fact that his doctor has him taking Toprol to reduce the pounding on his heart. And he doesn't need it for anything else, and he thinks he's experiencing side effects. So he wonders about the wisdom of taking Toprol and will it help his aorta?
So back up for a second. Does he have a blockage in his aorta, or? I mean, we're talking about two different things. We're talking about taking the Toprol. I'm confused about why he's taking the Toprol.
He said the doctor said it's to reduce the pounding on his heart, and I only have this in a written form and can't ask him a question back.
Well, so, you know, beta blockers in general are good, and they have been shown to decrease your cardiovascular event rate. They decrease the amount of stress that's on your heart. They also lower your blood pressure. So in that sense, it helps decrease the progression of vascular disease. Not that it's been proven or shown or anything, but it just helps decrease the stress on your heart. So I don't know exactly they're referring to.
He did write in and say that he wrote in and said he doesn't have a blockage. So it's just kind of protective, I guess, that the doctor's thinking.
Yeah, I mean, there should be a reason that you're on the beta blocker, but in general, there is a good cardioprotective, you know, for the being on the Toprol. I mean, I take it, you know, I take Toprol. But in regards to, and there was a question about large, what did he want to know about large blood vessels?
Well, is there a difference in the way PXE, or how does PXE impact small, medium, and large arteries?
Okay. Well, in general, most commonly it affects the medium to the small blood vessels, but it can affect the large blood vessels. It just affects it kind of in the outer layer and then in the inner layer, and kind of gets more progressively calcified as time passes, but it's not as common as the medium to small blood vessels, which is a majority of what's seen in PXE patients as far as we know.
Okay. Excuse me, I've got to go find the question now. someone wrote in and said that she has her feet go dead feeling when she's exercising, and she has peripheral artery disease, and after 20 minutes on a treadmill they go dead feeling. What would you suggest for her?
Yes, it's an unusual complaint, but it can be due to vascular disease. So first thing I would do is a physical exam to check her for pulses. And then if I couldn't feel pulses very well, which she probably already knows, if her pulses are hard to feel or not, then I would then follow that up with an ABI, which is the blood pressure cuff, and you compare it from the arm on the leg. And that can kind of give her an idea about what range she's in as far as severity of the blockages.
And then one gentleman who had the ABI kind of testing 3 years ago, he wonders if you're recommending that yearly or
yes,
even in the
yes.
Okay.
No. Back up. If you have palpable pulses, then you can just be followed with a pulse exam, assuming that you have a good physician that's able to check your pulses yearly and say, yes, they feel good, you're fine. And then if there's any change in your pulse where you have a hard time feeling your pulse, or you have symptoms of vascular disease in your legs, like what I described, then you want to proceed with getting an ABI. But if you have an abnormal ABI, then you need to continue to have ABIs and follow them at least yearly, depending on the severity of disease and what's going on. But you don't want to, if your ABI is 0.6, then you need another ABI and 6 months to a year to continue to follow that.
Okay. And then, do you have any suggestions of what kinds of drugs or aids you would suggest to help someone quit smoking?
Yeah, that's a tough one. The most important things are the ones that I discussed. Trying to quit with a group has been shown to significantly improve success. Making sure that the people around you are not smoking. Your loved ones need to quit smoking too. And then in regards to the drugs, some people do really well the drugs. I know at one point literature was saying that Chantix has a 40% success rate, but there's significant side effects in every drug that you take, so you need to discuss that with your doctor and be aware of what the side effects are. Some people had some psychological disturbances with the Chantix, and some people had success with it. So unfortunately, everybody, it's a psychological and a physiological and a habit, that is very hard to break, and everybody has their different inner workings, for why they smoke and how they need to quit. So a little bit of it has to be determined by that as an individual as well.
Mm-hmm. Thank you. Now here's a woman who said she used to have numbness in her feet starting in her 20s. She has PXE, and it was very hard to find the pulses in her feet. But she's been doing a very intense cardio exercise regime, spinning classes 3 times per week, and other things on most days. So she says the numbness has been reduced, and her pulse is stronger. So is it possible that she has... Sorry?
What did you say about her pulses?
Pulses are stronger now.
Oh,
so,
how good. Okay.
So has she reversed some of her peripheral arterial disease? Is that possible?
Well, the only reversal of arterial disease that they have shown was through statins. But I think that what happens with exercise, I don't know if a reverse is the right way, but your arteries do become more healthy by exercising, and they also grow other blood vessels around to compensate for blockages. So yes, I think that your blood vessels are healthier, and you may have reversed some of the blockages and some of the damages, or you may have grown blood vessels around to compensate for those blockages. And what you have done is what I have to beat my patients over the head with to try to do, because it's very hard to do because you have pain when you exercise, but it prevents you from needing surgery, and it's just great. I'm proud of you.
She also said she changed her diet, which lowered her cholesterol just from changing her diet and the exercise. So she's done everything you've recommended.
Great.
Here's a question from a gentleman who had a gastric bypass for weight reduction to decrease his overall health risks that were associated with being obese. And he's a PXEer. He wonders if the bypass increases the risk of intestinal or abdominal bleeding or blocks associated with GI risks. Okay.
No. Well, did he, I guess my question should probably, because I don't know exactly what kind of bypass he had. There are some complications that can occur when you reroute the bowels like that, but it's very unlikely that it would exacerbate any particular PXE problem. If he does have a GI bleed, though, then he'll have, more complicated surgery because he's had the previous gastric bypass, and adhesions and things aren't normal. Like, they won't be able to do the scope in certain areas to see, where the bleeding is coming from. But in general, I want to say no, that it wouldn't affect the PXE much. But I'm saying that, and I realize that I don't know exactly what surgery that he had.
Okay. Okay. I have a lot of questions coming in, so just a second while I read through them. Here's a question from a woman who has PXE and with no manifestations except angioid streaks, but she also has had diabetes for 42 years and retinopathy. One of those conditions is causing bleeding and swelling in the back of her retina. Let's see. The surgeon, she's about to get retinal laser surgery, and the surgeon is not sure which condition is causing the problem. What will guide him, and what about the surgery is most risky to my vision? Now that I'm reading the whole question, I'm sorry for this, Andrea. It sounds like a question for a retinologist, but if you have any opinion.
Yeah. No, I don't have. I mean, I know that the diabetes is usually macular degeneration, and then, of course, PXE is the neovascularization that occurs in the cracks in the membrane. So, I'm not sure exactly what he's seeing when he does his retinal exam, but I probably need to defer to the eyeball folks for that one. And I think you ought to do it before you have your laser done, because the Lucentis has been shown to significantly improve or halt or improve some of the visual changes that happen due to PXE. So that might be something that you need to look into.
Very good. Someone wrote saying, a woman saying she's had for several years trace blood in the urine, and she went to a urologist for further testing, and nothing was found. Could it be related to her PXE? She just found out early this year that she had PXE.
How old is she? You
don't know. And she may write that to me.
Yeah. So microscope, and I'm not a pee doctor, but microscopic blood in the urine.
She's 52, by the way.
She's what?
52.
52. Microscopic blood in the urine can be due to, kidney stones, which doesn't sound like she's having, or it can be due to polyps or some type of abnormality in the inner lining of the bladder wall. So did they, I guess my question, if it's persistent, meaning if she has at least 3 urines checked and it has microscopic blood and they don't know what's causing it, then they may want to take a scope and look with the scope inside her bladder and see if there's anything going on there. But I think that it's unlikely that it's due to the PXE. I haven't read in my extensive lit search anything involving the urinary tract other than case reports of kidney stones. So at this point, based on my limited knowledge, since I'm a blood vessel person, I'd have to say it's probably not related to the PXE, but it may need to be further investigated.
Mm-hmm. And early in the presentation, you said that having even one mutation in the ABCC6 gene is correlated with an increase in cardiovascular risk. So are you saying that parents of a person with PXE who are carriers have a higher risk of cardiovascular?
Yes.
And is it any of the mutations or specific ones?
There was I found that paper when I was doing my lit search. And I don't remember that they went into that specifically, but I did think it was fairly interesting. But it is a genetic thing; it's not something that you can change. So,
and so, should a person with the question is, should that person, a parent who's having any irregularities, consult a specialist?
Well, if they're having any symptoms, anybody having any symptoms should consult the specialist. But of course, being a vascular surgeon, I encourage anyone to do the risk factor modifications that we talked about to try to maintain your vascular risk. But even more so, if you do have the mutation or possibly have the mutation, it's even more so of an incentive to do those things.
Mm-hmm. Okay, and there's another question from someone in the UK who says there's a machine he's been made aware of called a circulation booster. It's a type of TENS unit, which TENS units have something to do with pain relief sometimes. Have you heard of that, and would it help prevent vascular problems, do you think?
I am not familiar with that. I apologize. I don't.
Okay. And here's another question from someone in the UK who has been advised that statins and exercise 5 days a week for 45 minutes is shown to be as effective long-term as having a stent. Is that the research that you were talking about?
Well, what you want to do is you want to do the statins and the exercise so you don't need a stent. And then if you do have a stent, and you do the statins and the exercise, that can help to keep your stent open longer. So comparing one against the other, it's always better to do the risk factor modifications, in my opinion, because if you put the stent in and you don't do the risk factor modifications, the stent's going to get blocked up just like your regular artery got blocked up. Mm-hmm. So, you know, I'll always pick the risk factor changes over the surgery.
Okay, I think that is you've addressed all the questions. You've been with us for almost an hour and a half. I thank you again very much, Andrea. A lot of interest in this and a lot of need to hear what you've been telling us. So thank you so much for being with us tonight.
Okay, thank you much.